Let's go ahead and get started. So welcome to the Society of Thoracic Surgeons Congenital Heart Surgery Database monthly webinar. Today is Tuesday, January the 18th of 2022. So welcome everyone. For today's webinar, let's see here. On the call with me today from the STS side, we have myself, Carol, we have Addie, we also have Chsd, our CHSD consultant, Emily, let's see, and Sydney Clinton for to answer any and all public reporting related questions. So thanks from the STS team for joining us. For our surgeon leadership, let's see, we have Dr. Meyer and Dr. Subramanian on the call. From core group, again, we have Chsd, Janet, and I don't think Leslie is on today. So, and from the IQVIA team, we have Jean, Joe, Michelle, and Steve. Leslie. Melanie's unable to join us today. So I know we just had a call last week, so I don't have a lot of new STS updates. So I'll just give a brief STS update, and then we'll turn things over to Chsd for our STS education today. Then we'll wrap things up with the IQVIA update, and again, end with your user feedback with your questions. Again, if you do have questions, please be sure to submit your questions via the Q&A function. Also, we do have the raise hand function enabled, so if you need to raise your hand, we can unmute you from this side. Please be sure your microphone's enabled and so we can hear you. And I think that's about it. So let's go ahead and get started. For our STS updates, the January training manual, actually, I did not update this, but the January training manual has been posted. So that is available on the STS website. So again, the January training manual has been posted. The 2021 harvest update, again, just a reminder, as you all are very aware, the harvest closed Thursday, December 23rd, and that data is over to DCRI for analysis. Again, just a reminder for anyone that wasn't on the call last week, the COVID update and official STS communication was sent to all database participants on 12/28. And that notification did indicate that any COVID positive patient will continue to be excluded from the current analysis. That's the 2021 and spring 2022 analysis. These COVID positive patients impacts about 0.19% of all the patients in the CHSD database. So that is a very small number. The communication also stated that analysis exclusions will cease for any record with a surgery date of January 1, 2022 forward. So again, OR date, certain cases that have OR dates of January 1, 2022, if they are COVID positive, they will be included in the analysis. And as always, STS would like for you to continue to collect these COVID variables until further notice. So please continue to collect those until you hear otherwise from the STS. Just including the 2022 harvest schedule, the spring 2022 harvest currently underway is scheduled to close March 11th, opt out March 15th. And again, that 2022 spring harvest will include procedures up through December 31st of 2021. And then the fall 2022 harvest is scheduled to close on September the 16th with opt-out date of September the 20th. And the fall harvest analysis report will include procedures up through June the 30th of 2022. 6.22 data version upgrade. The data spec build, no changes from last week. The data spec build is in the final stages. We are hoping to get those specs to the vendors by the end of this month. We are having final phone calls this week and wrapping things up. Upgrade webinars will begin in February. I have the dates for those. I'll provide those to you at the end of the presentation here. But we are starting those on February 1st. So we will do a DCF walkthrough, and of course you will have the opportunity to answer questions. Again, on these upgrade webinars, we will go line by line, section by section. So if you are unable to attend the calls, please know that they will be recorded and posted out on the STS website for you to download and listen to if you're unable to make calls on specific days. Our 2021 and 2022 analysis updates, there will be an official communication that will be sent to the CHSD community. You all had asked for another communication. So that will be coming. I am working with Dr. Subramanian on that communication. So for 2021, just a reminder, there will be the implementation of the 3.41 more granular codes, and those are listed here on the slide to the right. Again, these more 3.41, these more granular codes will be implemented into the analysis. Also in 2021, we were adding 3 additional rules exceptions that will be implemented, and Chastity will go into more detail about that here in just a moment when I turn things over to her. And then for spring 2022, just a reminder that the updated stat scores will be implemented into analysis. These updated stat scores will be applied retroactively. They will be applied to the entire 4-year analytic period. So they will be applied retroactively to data. So these updated stat scores will be applied in spring 2022 analysis, and that reporting period includes OR dates of January 1, 2018 through December 31st of 2021. All right. That's all that I have. So next, I'm going to turn things over to Chastity for her STS education. So Chastity, the floor is yours.
All right, great. Thank you, Leanne. Next slide. So in today's webinar, as you know, it's our last webinar before we break out into our upgrade webinars. And so I grabbed a couple of what I thought were important educational topics from the questions that you all are submitting to the portal and or sending me emails about. And so I thought that these would be great to kind of highlight and touch on before we go into the upgrade calls. So there's some definition clarifications, as well as Leanne talked about the 3 new primary procedure determination rules that will go into effect with our current analysis that we expect that data back sometime this spring. Next slide. So we'll start with the definition clarifications. And so we're going to start with chylothorax. We continue to get many questions about the complication of chylothorax. And when we look at this as the core group, when we look at this definition, we can definitely see that it's wordy. I think it has a lot of detail and is well written, but I think it's wordy and difficult to get through when you have a patient and you're trying to figure out, does it meet all this criteria, any of this criteria? What do I need to do? So next slide. What we decided to do was take this, we didn't change the definition at all, but what we did was we're gonna update the training manual to make it, I think, what will be more, it'll assist you with the coding. It'll be easier to get through when you have a patient that you're trying to see if they meet this definition. So the definition remains the same. There on the left, the presence of lymphatic fluid in the pleural space, commonly secondary to leakage from the thoracic duct or one of its main tributaries. Thoracocentesis is the gold standard for diagnosis. From there, we're going to say code this complication if there is biochemical evidence or lab evidence where you have a predominance of lymphocytes and or a triglyceride level of greater than 110 milligrams per deciliter, and placement of a new chest tube, or if you have an existing chest tube that you have high outputs of greater than 10 mils per kg per day for at least 48 hours or greater. And one or more of the following: that you have a chest tube that stays in place for greater than 7 days, a change in your enteral diet to a fat-free diet for greater than 7 days, or NPO or parenteral nutrition and lipids for greater than 7 days, medication such as octreotide, albumin, or IVIG infusions at any time, or a surgery for a chyle leak. So you need to have biochemical analysis or lab values that support the diagnosis, as well as a new chest tube placed or high outputs from an existing chest tube, and at least one of the treatments before you can code a chylothorax. So I think if we write it this way, which again, it's the same definition, just breaking it up a little bit, I think it really does make it easier, that when you're going through your patient scenario, it will make this much easier for you. So next slide. We'll go through a couple of examples. So in this scenario, patient experiences a pleural effusion and a chest tube is placed. The labs reveal a triglyceride level of 200 milligrams per deciliter. A low-fat diet was instituted for 24 hours before a return to a normal diet. The physicians continue to document that there was a chylous effusion. So does this patient meet criteria for coding a chylothorax? Biochemical analysis is yes, so you had a high triglyceride level. Was a new chest tube placed, or was there high output from an existing chest tube? So yes, the patient did need a new chest tube placed. But does the patient meet the definitional treatment? So the patient only had a low-fat diet for 24 hours. So the patient really doesn't meet the criteria for coding a chylothorax in the STS database. Now, I know your clinicians may, continue to document this and code this, but the difference would be that it doesn't meet the definitions in the STS database. And we all want to be held to the same definition so that we're all coding this the same in the databases. And so I think that that's why it's really important to adhere, to this definition. So next slide. So additionally, if a pleural effusion is drained that meets the definition for chylothorax, you're also going to code the complication of pleural effusion requiring drainage. And so this is in the training manual, but I've just thought important to point out again that sometimes, we get really excited that we met the definitional criteria for a chylothorax, but if a new chest tube was placed to drain that type of pleural effusion, we also want to code the other complication of pleural effusion. Next slide. So the next definition that we're going to look at is for a preoperative factor, and this is mechanical ventilation to treat cardiorespiratory failure. And again, we get lots of questions about this as well. And I think the take-home message, I'm not going to read this entire definition to you because I think you're all probably quite familiar with it, but I think the take-home message here is that we're really looking for mechanical ventilatory support for cardiorespiratory failure. So this does not include elective periods of mechanical ventilation. So let's go through a few examples. So in this scenario, a patient was intubated upon arrival to the ICU following a cardiac arrest in the ED. After 7 days, the patient is finally extubated to CPAP, and the patient goes on to the OR for an Alcapa repair. So does this patient meet the criteria to code the preoperative factor of mechanical ventilation to treat cardiorespiratory failure? So yes, this patient required mechanical ventilatory support for respiratory failure. It occurred during this hospital admission prior to the surgery. And also you want to code the non-invasive respiratory support in that the patient received CPAP prior to going to the OR as well. So you would have two preoperative factors that you could select just based on the scenario. So next. Scenario number 2 is this patient was intubated at an outside hospital for airway protection prior to transfer. The patient extubated upon arrival to the surgical hospital. So does this patient meet criteria to code this preoperative factor? And the answer here is no. So the patient was not intubated or required mechanical ventilatory support for respiratory failure, as this was just airway protection for the patient's transfer. Next slide. In this scenario, the patient returned from the cath lab and remained intubated until their surgical procedure the following morning. So did this patient meet criteria to code this preoperative factor? And the answer here again is no. So the patient did not require mechanical ventilation for respiratory failure. And so you do not want to code again for elective periods of mechanical ventilation. And I think the best way to figure this out in your chart is to really read the documentation, or you're going to have to work with your intensivists and surgeons to figure this out as well. Mine do a really nice job of saying we plan to electively, keep a patient intubated overnight, as we don't want them to sustain another intubation tomorrow morning for surgery or things like that. And so I definitely find it documented in my record. If you don't, or you're having trouble, I think that it's a great time to meet with your surgical teams or intensivists to figure out how you can best determine if the patient was left intubated electively, or if something perhaps happened during the cath and that they required that ventilatory support. Next slide. All right, so in this scenario, following cardiac repair, a patient remains intubated until after their delayed sternal closure. Does this meet criteria for pre-op mechanical ventilation to treat cardiorespiratory failure for the delayed sternal closure procedure? So we get this question a lot, and it's in the training manual a few times. And I think the question here is, does the patient really have, respiratory failure, given we're electively leaving them intubated until that sternum's closed? And the answer is yes. So a patient that has an open sternum is incapable of taking a spontaneous breath because they don't have the ability to create a negative intrathoracic pressure to take that breath. So effectively, they have respiratory failure because they can't spontaneously take that breath, and they would require mechanical ventilation. And this, of course, occurred prior to the delayed sternal closure procedure. So yes, you would, in effect, code mechanical ventilation to treat cardiorespiratory failure for this scenario. Next slide. Okay, so the final definition I want to look at is under the hospitalization section in the database, and the field is the location from which the patient was admitted. And so the definition is indicate the location from which the patient was admitted. And was this from home, another acute care center, other chronic care center, or they were born at the operative center? And so when you're determining this, you really have to know, obviously, where a patient resides or where they were prior to coming to you. And this can be difficult sometimes in your medical records, but I guarantee that whatever unit the patient ends up on, an ICU or floor or whatever, though those providers do know where the patient came from, and you would hope would be documenting that. And the only way you can select born at operative center is if you have a birthing center at your facility. So for example, mine is a freestanding children's hospital, so I never ever can select that unless somebody was accidentally born in the hallway of my children's hospital, which I have not seen happen, knock on wood, yet. So next slide. And so I gave a couple scenarios where I've been asked a few questions about this field. So a patient admitted to the surgical hospital directly from clinic. It doesn't matter which clinic. The fact is the patient resides at home. So they were not admitted to another acute care or chronic care facility prior to the admission. So they were admitted from home, unless you have some other detail that, the patient does reside in a chronic care facility. Patient transferred from an outside hospital ED to the surgical hospital. So while this patient originated at another acute care facility in their ED, they're not admitted to that facility. And that's kind of a nuance, I think, to this definition. And it is already currently in the training manual. So an ED visit is not an admission to an acute care center. So they also came from home upon arrival to your surgical hospital. Patient transferred from the outside hospital NICU to the surgical hospital. This is where we would select another acute care center. The patient was admitted to the NICU at another acute care center and then transferred to your facility. And so that's the kind of scenario where you could select other acute care center. All right, next slide. So let's then wrap this up with primary procedure determination updates. And these are the new rules. I know Leanne touched on these last week, but I just wanted to, I think we can always hear about it over and over and over, and it's good for us. So knowing that these are 3 new rules that will be applied to the data that's currently sitting in the warehouse that we all just submitted at the end of December. And so you're gonna see these take effect. So next slide. The first rule is, and I know this is wordy because the procedures are wordy, so I think I can do a good job of explaining it, but you have all the detail here if you need it. So if any procedure that includes one of the Glenn Hemi-Fontan procedures, you're used to this list, the Glenn Hemi-Fontan procedures are already listed in the document that we use for primary procedure determination, but these are the same ones listed where you have your different types of Glenn's, Hemi-Fontans, as well as Kawashima. Also includes either your stage 1 and stage 2 hybrid procedures that are listed here, or a transplant of lungs, heart, or heart and lungs. The primary procedure will be determined to be the pertinent one from the second list of procedures, meaning the transplants or hybrid procedures that are listed there, and not one of the Glenn or Hemi-Fontan procedures. So this new rule came about because there were some programs where a Glenn or Hemi-Fontan was done in the setting of a heart transplant, and it was getting caught up in the report that comes out from IQVIA. And so that's why this rule was put into place, to make sure that the transplant or the hybrid procedures will take the designated primary procedure upon analysis. So next slide. If any multiple component operation that includes one of the below named pulmonary valve replacement procedures, so this is code 2270, valvuloplasty converted to valve replacement in the same operation, pulmonic, or code 600, valve replacement pulmonic, which is pulmonary valve replacement, also includes a PA reconstruction main, then the primary procedure will be one of the pulmonary valve replacement procedures and not code 530, the PA reconstruction. As you know, right now, if you code the PA reconstruction, which in fairness, our surgeons have done or are doing when we're doing valve replacement procedures, you know that the PA reconstruction main has a higher stat score than the pulmonary valve replacement procedures. And so we don't want this to happen. And so we want to make sure that the designated primary procedure will be one of the pulmonary valve replacement procedures. And this rule will take care of that. Next slide. In the event of the following simultaneous procedures, so where you've done procedure 610, conduit placement, RV to PA, is combined with any of the following procedures, so a Ross procedure or a Ross-Cono procedure, then the primary procedure comes from the following list unless the operation includes an additional simultaneous procedure with a higher stat score. So in effect, if you've done a conduit placement RV to PA with a Ross or Ross-Cono, which is a part of that procedure, the primary procedure will be the Ross or the Ross-Cono and not the conduit placement, unless you've done another procedure at the same time that has a higher stat score. And in the latter instance, the component procedure with the highest stat mortality score or procedure from the list under exception 1 is the primary procedure. So in other words, if you've done a procedure with a higher stat score, that would be the primary procedure. So please, if you have questions, share them in the chat. I'm going to turn this back over to STS to give their updates. Or I'm sorry, I think it's IQVIA giving their updates. But please put your questions in the Q&A, not the chat. I apologize. And that way we can get them answered at the end of this call. So if there's anything I've said that's confusing or you need more clarification, please, please, please provide that feedback and we'll make sure that we answer that for you.
Thank you so much, Chsd. Awesome presentation. We appreciate it. Next, as Chsd said, we're going to turn things over to IQVIA. I know they don't have a lot of updates from last week, but Joe is just going to again share the information from last week for those that were not able to be on the call. So with that, Joe, the floor is yours.
Thanks, Leanne. Good afternoon. So as Leanne said, we just do have a reiteration essentially of the updates we provided for you last week. Updates coming for the primary procedure mismatch report, STS 7662. We will be updating the report so that the priority of transplants when done in conjunction with Rule 1 exception codes is taken into consideration appropriately. STS 7666. The report will be updated to implement a new rule to address PVR procedures. STS 7667, the reports will be updated to include the new stat codes. STS 7678, the report will be updated to consider VSD repair patch code 110 as the primary when the report identifies a tie with the PFO primary closure code 100 when done in conjunction with the valvuloplasty tricuspid 460. And with the risk adjusted report, STS 7589, we will be applying updates to table 21 to remove results for procedure codes 1275 and 1285. And the timing of all those is TBD, so we don't have a release date yet, but those are the things that are being worked on. As the current slide says, there is a list of known issues and enhancements posted to the library. So if you want to review that, you can just navigate over to the library and find that spreadsheet. And the usual reminders that if we didn't discuss something today that you have submitted a ticket for, please feel free to follow up with our team and we will get an update for you. And we'll be working on presenting additional items for you in an upcoming release.
Awesome. Thank you so much, Joe. I appreciate it.
Thank you.
All right, so again, just a friendly reminder, analysis report questions should go directly to IQVIA tech support. They can be reached at chsdtechsupport@iqvia.com, and STS and DCRI will be looped in as those questions are escalated up to tier 2. My contact information is listed here. Database operational questions, please reach out to us at stsdb@sts.org. And again, I know I said this over and over, but if you have questions regarding invoices, you have questions regarding participation agreements, you have questions regarding the contacts currently listed for your site, please reach out to us at stsdb@sts.org. If you have questions regarding STS direct data entry through the IQVIA platform, again, reach out to Jane and her team at STSDB. And if you're not sure who to contact, just let me know. Reach out to me and I'll get you in touch with the right staff. Upcoming CHSD webinars, as I mentioned earlier, our upgrade webinars will be beginning in February. Our next monthly webinar is scheduled for February 15th at 12 p.m. Central Time. But again, our upgrade webinars will begin February 1st. Our first call will be February 1st at 12 p.m. Central. Our second upgrade webinar will be the following week, February the 8th at 12 p.m. Central. And then the next one will be February the 22nd at 12 p.m. Central. So each one of those calls will be an hour long. We'll, again, as we stated, we'll go section by section, line by line on each of those webinars. And I'll post on our monthly webinar, I'll get the dates for March and April. So again, February 1st, 8th, and 22nd, we'll be kicking off our upgrade webinars, and our monthly webinar is scheduled for February the 15th. All right, that's all that we have from the STS perspective and IQVIA side today. So I do see some questions coming into the Q&A. So let's go ahead and begin tackling those questions. All right, I'm going to put these dates back up in case you guys want to jot those down for any reason, or go ahead and get those added to your calendar. All right, our first question for Krista. We use Medics as a vendor. I'm concerned about them having the 6.2.2 version update ready on July 1st. They have said some things suggesting they aren't sure if they will be done on time, as they haven't gotten the spec sheet. What happens if they are not ready? Will the go live be postponed? So at this time, there is no there's no talk about postponing the go live. So if your vendor is not ready come July 1st, you'll have to collect data on paper. Just to keep in mind, the first harvest that will include the 6.22 data will be the spring 2023 harvest. So 6.22 is scheduled to go live July 1. And the first time that data will be harvested will be the spring 2023 harvest. I don't know, Carol, did you have anything to add regarding that? But I know in the past, if vendors aren't ready, the sites collect on paper until then.
That's right. Yep. Yeah, I don't have anything. Just it's important to note the first time we harvest the data won't be until March 2023. So.
Yep. And Krista had a follow-up question. She said, would it be possible to have a PDF of the specs that we could take note on during the upgrade webinars?
So we won't post the specs until the vendors start getting certified. And the reason we do that is for version control. It is likely that when we send the specs out, the vendors are very meticulous in their build, and they oftentimes may note small discrepancies where we have to go in and change the specs. So we don't post the specs until the vendors start getting certified to make sure that we don't run into those issues with version control. The best thing, I think what we're working on to provide sites, and Leanne, you can probably provide more detail, but is a DCF with the all of the changes marked on a DCF, and then a clean version with the new fields added, highlighted. And then, so we'll be providing those, right, Leanne? Is that
yes,
right?
ma'am.
I don't want to say that you're doing that. I think that's the plan.
I'm working on it. It's a labor of love, as you are very much, as you're aware.
You can certainly take notes on that DCF, but also the webinars will be posted, and they're not going to go anywhere. They'll be posted on the STS webinar page, and then on the STS CHSD YouTube channel for you to watch at any time. And I think it's a good plan. It worked with the other databases very well when we've done this. And, we provide about 30 to 40 minutes of education, and then leave 20 to 30 minutes of time for Q&A, just specific to the upgrade and the sections we reviewed, to keep it very focused. So I think it's a really good plan, and hopefully it'll work well for this upgrade too.
Thanks so much, Carol. Diane has our next question. Where can I find a list of the new updated stat scores? Dr. Meyer, did you want to? It looks like you had indicated you wanted to answer that question, but I don't know if you did that on purpose or accident.
No, I'll answer.
Yes, sir.
It's published in the World Journal for Pediatric and Congenital Heart Disease, volume 12, and it begins on page 246 and ends on page 281.
And also just, I will be updating I know we have Appendix C that's currently out there now. I will be updating that document and posting that out on the STS website. I am in the process of finalizing my document of all the stat scores now. It's very, I'm taking my time and going through this document to make sure everything is correct. So it is a very tedious process, but please know that I am working through that document and getting that finalized. And Dr. Subramanian did put a link into the paper in the chat box. So thank you very much, Dr. Subramanian. I know Kelly has her hand raised, and I think it's regarding this question. So Kelly, I'm going to unmute you. So I'm assuming that's why you have your hand raised.
Yes, it was. I'm just wondering if we can post that document on the IQVIA resource website as well.
Oh, yes, yes, it'll get posted in both locations, yes.
Okay, and then I do have a couple other questions, but those can wait if.
Okay.
Yeah,
Well, I mean, go ahead.
Okay.
Go ahead. Yep, we have time. We
Okay.
have. Yeah, go ahead.
All right. So we have multiple changes that are going to be applied to retrospective data. The new stat scores, the new determination of primary procedures, the PVR rule. And we use the IQVIA data quality report to analyze our data and to ensure that our data are accurate. They align with what our center is showing. That's going to be extremely challenging for us to do if the enhancements are to be determined. Do they have a timeline? Does IQVIA have a timeline for when these enhancements will be completed? Will we have ample time to finalize our harvest and ensure the accuracy of the data?
Yep, I can take that. I know Melanie was unable to be on the call today, so I apologize for that. But IQVIA is working on the timeline. Melanie is working with her development team to get us a timeline. These changes will be the primary procedure mismatch report, and I think Marjorie's on the call as well, or Marjorie or someone from the IQVIA team. But these will be implemented. You know, IQVIA working to get this implemented prior to the harvest close date, so you all will have ample time to work on the data quality, work with the data quality report with these new rules in place on the IQVIA side. So the goal is to have these implemented prior to the harvest close to allow you guys plenty of time to work with that to make sure that your data is accurate.
Okay, are we anticipating like 1 week or 2 weeks, 3 weeks?
The
harvest close is what, like 8 weeks away, I guess, is that right?
Yes, it's mid-March. Yes, it's mid-March. So as soon as I have information and I touch base with Melanie, I know the IQVIA team is working, and as soon as I can give you a time frame, Kelly, I will. I don't have a date right now, so okay. I will provide that to you as soon as I have it. Yes.
Can I ask a question regarding that also?
Sure.
Will IQVIA be putting something in place to flag the combined procedures so sites know which ones are going in with the new combination codes?
I don't, honestly, Janet, I don't know the answer to that off the top of my head. I'd have to touch base with Melanie. And I don't want to answer that question with her not on the call because I don't want to say anything incorrect.
Those won't be until 6.2.
6.22, right?
Yeah.
So that would not be happening until 6.2, until that go live date in July.
But the data will be analyzed using the combo codes. So sites will have to understand that their data locally will look different.
And Dr. Subramanian is saying that it will be part of the stat document that Leanne is putting together.
Yep.
Yes, so Janet is correct. Hi again, this is Dr. Subramanian. Sorry, I should introduce myself first. Dr. Subramanian. Janet, Chastity, Leanne, everybody's saying all the correct things. The new stat scores will actually go into vogue when we analyze the data from the spring harvest that is slated for March. These will include the new combination codes, but they will be done in the back end like we already do, which is if you enter truncus and intrapedagogic arch as two separate entities right now into the data collection form in the current version, we have mechanisms in the back end to combine them into a composite procedure and apply the composite stat score. That's the only way these new composite procedures will be handled in the March harvest because those combined procedure codes don't exist in the current data collection form. I think that's what Janet is talking about. Once the new DCF comes into vogue in 622, data managers will have the opportunity to directly pick the combination code. That said, we will maintain the programmatic algorithm in the back end, which will create combination codes if the data managers choose to enter them atomically into the database. So rest assured, it is not going to be any more data burden for you, either in this or in the future versions. And we will do everything possible to set up a programming that does the correct thing at the back end. I hope I answered that question.
Thank you, Dr. Subramanian. I appreciate it.
I
yeah,
have
Kelly,
one
go
more
ahead.
question, Leanne.
Yeah, go ahead.
I know in the beginning of this webinar, you had mentioned that you were working on communication to the data manager community, the STS community about these new changes.
Yep.
I know that I've brought these changes to leadership and trying to explain to them that these changes will be applied to retrospective data. They have been, it's not been well received. So, and then actually some of our surgeons aren't even aware of this. So, and there are lots of questions. When is this communication going to come out? Do you have a timeline for that?
Kelly, I'll take that question. That's an important question. I really want to clarify this for all the data managers on this call and for your cohorts, whoever you're going to talk to. I know we use the term, we're applying this retroactively. That's not the impression I want to leave you all with. Please remember that these stat scores were empirically derived. If you read that paper that Marshall Jacobs and all of us wrote that I put in the chat box, if you read that paper, these stat category, stat mortality scores, the so-called stat 2020 scores, were derived from surgeries that were done in the time period that is being included in the analysis right now. For example, if you go back and read the abstract of the paper that we posted and that's going to be distributed, you will see that these new stat 2020 scores were actually validated on 46,933 operations that were performed from July 1st, 2017 to June 30, 2019. So remember that the analysis we're doing in 2022, in March, when these go into effect, will include surgeries that were done in 2018, 2019, 2020, and 2021. So this is actually being applied to the same data set from which they were derived. In fact, your surgeon leaderships and you all as data managers and the participant, C-suite should view this very positively, stating that by allowing this to be utilized for 2018 and 2019 operations, the STS is actually now applying more statistically relevant, contemporary, verified, and highly reliable peer-reviewed stat mortality scores. We will make sure this goes out into the communication. As you can imagine, any formal communication from the STS is not something Leanne and I can approve and say, okay, send it out. It needs to go through media and public relations and all of them. So we're working on it. We'll make this abundantly clear, but I also want to offer my services. Leanne knows how to get a hold of me. Y'all know how to get a hold of me. I am happy to talk to your surgeon leadership and explain this. I'm actually extremely thrilled that task force chairs before me, Dr. Meyer, Dr. Jacobs, set us up to implement these stat scores. And so I'm thankful to them because I really am excited that these new stat scores are more reliable and more valid.
So, Dr. Subramanian, thank you for that explanation. So I think my concern is this actually, so an example, you are actually applying, for example, the new rules to determine the primary procedure that Chsd just explained to 2018, 2019, 2020, 21 data that has already been analyzed. So now published, and now we're going back and changing the rules to determine that. And we're applying different stat score changes to that historical data that has already been published in prior harvest reports. I understand that the model has become more robust due to the analysis of the historical procedures, and there was a need for the stat score changes and some of these changes. That makes sense. What I don't quite understand is going back and applying these rules to historical data that has already been analyzed, and why we're not doing this prospectively.
Yeah, no, you're asking an excellent question. Those were discussed extensively at the task force level. So the only rules that we're applying retroactively right now are rules where we think the current application of the database is probably not the best application of the database. In other words, the one example that's on the screen right now, what we have found out from the audits, so when our auditors went around the country and audited people for PDRs, there are some programs that routinely go in, and when they place a pulmonary valve in the RV outflow tract, in order to accommodate a bigger valve, put a patch on the RV outflow tract. And the data managers appropriately code it as main PA reconstruction. The intent of the operation clearly is to do a pulmonary valve replacement. The main pulmonary artery did not require pulmonary arterioplasty. It wasn't like it was narrow. The surgeon made a judgment call. In doing so, if we blindly apply the rule of saying in a composite code, the highest stat procedure becomes the primary procedure, we are favoring a surgeon-made judgment approach. And we felt that we needed to go back to intent and make intent the primary procedure when it made sense. There's plenty of precedence for this. This is not new in the congenital heart surgery database. A classic example I will give you is BT shunt takedown at the time of Glenn. So, people, they had a, let's say, triatresia, had a BT shunt, you went back and took the BT shunt down and did a Glenn procedure. BT shunt takedown is the higher stat mortality procedure. But there is an existing exception that says in the setting of a Glenn, BT shunt takedown will not become the primary procedure. Like that, intent, we're adding this as an exception to primary procedure code. Yes, you are correct in stating that it will change primary procedure assignment. It will, but we believe that that's actually a favorable thing to do to prevent this aberration. And I sincerely use the word aberration, that main PA plasty was not the intent of that operation. Our auditors felt that this happened so frequently that we needed to address this. And that's the background for this. So I think it's grounded in reason. It just requires better communication, which I'm happy to do with the surgeon leadership in any institution.
Okay, and we'll make this very clear that these changes will be applied to what it's 2018 data moving forward, correct? Is that right?
Yes, this will all, wait, the new stats code is 2018 moving forward. Right, Leanne?
Yes, sir.
Can I add something to help make this make a little bit more sense? I think what we need to do is we need to look at our sample size. And in order to have useful length of stay benchmarks, mortality benchmarks, benchmark procedure benchmarks, and risk adjustment models, we need to apply the same set of rules to a 4-year data window. Because in congenital, our sample size is so small that in order to get the statistical significance and the power to draw any conclusions, we need the 4-year window. So I think, Kelly, when you're talking about this, since we're changing 50% of the stat scores, we really need a 4-year analysis block in order to say that, our length of stay for our stat 2s using the current mortality information is different than it used to be. So I think that's also a way to consider sample size. Does that help a little bit?
Yes.
Yeah, Dr. Meyer, I think you had something to say as well.
Yeah, I think probably step back from the details. I think the fundamental message is that we have tried to update and make more up to date the risk adjustment method by the processes that Dr. Subramanian explained. But what that means is that what your results were in the last harvest may or may not be comparable to what they are in the current harvest. So the absolute numbers, are almost certainly going to change a little bit for everybody, for every institution. Theoretically, assuming nothing else changed, the relative relationships between the various institutions shouldn't change. So the things that will change, though, is that your mortality rate for a stat 4 procedure, what used to be a stat 4 procedure, and under the new scheme is a stat 2 procedure, well, that's going to change your stat 4 mortality rate. But that change was made because across the entire database, that procedure didn't warrant being in stat 4 categories anymore. And it was more appropriate that it got moved to a stat 2 as an example. So I think, we could go round and round on this for a long time. And I think there are a lot of arguments, but I do think that ultimately, in terms of within your institution, people who are going to look at and think about and talk about the data, I think what one has to say is that, just remember this report is not comparable and should not be compared to the one using the prior methodology.
Yeah, thank you, Dr. Meyer. I think that sums it up. I know from a data manager perspective, our leadership asks that we be able to essentially predict what table 1 will look like. I think that's going to be difficult for us to do that. And it would be very helpful if the STS could relay that communication, that this is going to be difficult, that there will be a mortality perhaps that was a stat 2 that might be a stat 4 or vice versa. So it's going to look very different. And I think communicating that will be helpful for us.
Right. And the problem is that whenever you make a change like this, you make a change. And so the new methodology is not exactly comparable to the prior methodology because we think the new methodology is better. It's been refreshed, if you will. The scores and everything have been refreshed by more current data and more, therefore, we think more valid data. So, it's a trap that I think is easy to fall into, that we're saying, gee, last year our stat 4 mortality rate was 4%, and this year it's 6%. Well, you just can't compare them because there are different procedures that are in each one of those stat risk levels, for instance.
Mm-hmm.
But we have valuable information to share with our patients and our families that's accurate with the current mortality, which has changed since it was 10 years ago.
Mm-hmm.
Absolutely.
Yeah, and that all makes sense. Yes. I think it would be helpful to communicate these changes and that it come from the STS.
I completely agree. Yeah. I think it's all about our job, I think, is to set the expectations and present the realities so that people don't misinterpret or misconstrue the information that's coming back in the new report.
Correct. Yes. Thank you very much.
Excellent. All right. Thank you, Kelly. Let's see here. So Chastity, we have a question for you from Maggie. One of my facilities shares a campus with an adult hospital with a birthing center and NICU. The hospitals have separate names, but share some physical facilities. If a patient transfers from the NICU at the adult hospital to the children's, would this be a transfer from another acute care facility or born at Operative Center?
Maggie, this is a fantastic question. Janet, did you have something to say?
Yeah, because it depends on, sometimes the NICU at the adult hospital, if it's on the same campus, is actually under the NPI number of the children's hospital. So then it would be considered at the birthing hospital because they're under the same NPI number. So that's how we have sorted it out in the past.
Yeah, and I think, Maggie, I was going to ask you to submit this to the core group because I think it's an important question that we answer and have in the training manual. And the MPI number, I think, of the hospitals is a great way to look at that. I would also ask you, how are you doing your preoperative factors right now? For between these two centers, because if you're not a birthing center, there are some preoperative factors that you don't get to select. So for me, if a child was born, let's say across town at your facility and transfers to mine, but they had some ventilation time at your facility, I can't select the preoperative factor of mechanical ventilation for respiratory failure because it did not occur at my hospital. If I were a birthing center, I would be able to collect that information. So one of my questions to you would be, how are you handling your preoperative factors? Because I'm assuming that question's been answered for you before as well. So why don't you submit this to the core group, and we will discuss it at our next call in February and get a really robust answer out to everybody. Great question, Maggie.
Thank you. All right, our next question from Barbara. Barbara at Children Mercy. Doctor wants to know if there's still a data analysis database document he hasn't seen in a while. He thought it was very useful. So yeah, let me pull this over. So I think you're talking about the analysis overview. So for the congenital database, and if you go into the library, if you click here, the very first link up at the top, this is the CHSD analysis overview. And I believe this is what you're talking about, Barbara. And just download that document. And this has been revamped. We shortened the interpretation guide. It was over 100 pages in previous reports. So we have shortened this document considerably, but I believe all of the information that you need can be found in this document. So that is found within the IQVIA library. If you don't find what you need in this document, you can just email me and I can point you in the right direction. And also, if you're not aware, there is a risk-adjusted report calculation spreadsheet. So if you all have not downloaded this document, I do encourage you to download it and take a look at it. This calculation spreadsheet document lays out, let me pull this over, all of the calculations that are included in the reports out on the IQVIA website. So if you're looking into table 24 and you want to know what's included in certain lines of report, I encourage you to download this document, take a look, and it outlines all this. And I know Melanie had talked about doing a deeper dive into this document in one of our webinars. So I will work with IQVIA and Melanie to provide some education on reading that risk-adjusted report calculation spreadsheet. So just wanted to point out those resources that were available to you. And I think that's what you're referring to, Barbara. If not, please let me know. Let's see here. Amy, there's a question from Amy Chsd, Dr. Subramanian. If an RVOT procedure code 510 stat level 2 is coded along with PVR code 600 stat level 1, will the RVOT procedure remain the primary procedure? Does the new change only apply to code 530, the PA reconstruction?
So it will only apply to the procedures for which it will apply are the procedures that are listed in the document that you put up. The other procedure exception will not apply to. The pre-existing rule will continue. Okay.
Thank you. And I think Igor was just making a comment saying that when we were talking about the changing, applying the rules, I think he was just stating that the report will be different for everyone. So it's not just, individual affecting individual institutions, but it'll be overall those stat scores and having mortalities in different stat categories, that's going to be applied, across the board. Are there plans to rerun the harvest report that was published in October? No, Kelly, there are no plans to rerun the harvest report that was published in October. Let's see here. And I think, Barbara, I answered all of your questions. I accidentally dismissed one of your questions or said that I had answered it live, but I think I had gone back and answered your questions.
I think it was just the part that said
the pages.
Yeah, referring to the pages.
Okay, perfect.
But I don't know that her question was answered.
Yes.
Okay.
All right. I don't see any additional questions come in. I don't know if Dr. Meyer or Dr. Subramanian have anything they wanted to add. I know we are coming to the end of the hour. I personally do not have anything to add. And again, just mark your calendars for the upgrade webinars. We're going to make use of the user group calls that we have on the calendar. So again, the upgrade webinars are scheduled to start February 1st at 12 Central, followed by our next one the following week on the 8th. Then we'll have our monthly webinar on the 15th and finish up the month of February with our last upgrade webinar on the 22nd. Okay, I don't see any additional questions coming in. So thank you everyone for joining today. Again, if you have any questions after the webinar, and if you need to reach out to me directly, my email is here. And thank you, Dr. Subramanian, Dr. Meyer, Chsd, Janet, STS team, IQVIA team. Thank you all very much for your help on the webinar today. So with that, I hope you guys have a great rest of the week. Thanks,
you,
everyone.
Leanne.
I appreciate
Thanks,
it.
Leanne. Great job. Thanks,
Thanks, guys.
everybody.
Thank you.
Thank you, everyone.
Thank you.